Okay, well, it's 11 o'clock, so I'm sure people are still going to be trickling in as their 11 o'clock or 10 o'clock meetings are ending. But I'm going to go ahead and give a brief introduction so that we can get started and have plenty of time for questions. Welcome to the second Spring 2020 BEAD Core Research Seminar. I just wanted to make a couple notes. We will be, the presenters will be handling the questions in the chat, so please feel free to post your question using the chat function, and the presenters will review those at the end to answer questions. Make sure, I believe everyone's muted upon entry, but double check please so that we don't have any accidental noise in the background. Also, after this presentation, you'll be receiving an evaluation by email, and we would really appreciate it if you could take a moment to fill that out. It really helps us understand how to improve our seminars in the future and what kind of ideas for other themes that you might like to hear. It really guides the way that we make our decisions at BEAD Core when it comes to these seminars. Also, anyone out there who's interested in research support services, please email beadcore@jhmi.edu and we can help get you started. So without any more delay, I want to introduce our presenters today. We're so grateful that they're here with us. We have Claire Snyder, who is a professor of medicine in the Division of General Internal Medicine and also the program director for BLOCKS, which is Building Lifestyle Outcomes in Core Services Research in Cancer. We also have Michael Brundage, who is coming to us from the Queen's Cancer Research Institute in Canada. So welcome, and please. Go ahead, Claire.
Thank you, Laura. And on behalf of Michael and myself, we're pleased to be with y'all today virtually to talk about research that we've conducted investigating data visualization for patient-reported outcomes. And we appreciate the BEAD Core for organizing this seminar. And the research and work that we are presenting today was funded by the Patient-Centered Outcomes Research Institute, and we're grateful to PCORI for their support. To give an overview of what we'll be covering today, I'm going to start with a brief introduction to patient-reported outcomes to make sure that everyone is on the same page in terms of when we talk about PROS, as well as the rationale for the research agenda that Michael and I and our collaborators undertook probably now about 7 years ago, my goodness. And I'll talk about the methods that we use for our research studies, and then Michael will present the consensus recommendations that emerged from our efforts in terms of how to display PRO data to promote understanding and use. And then we'll conclude the session by mentioning some additional tools and resources that are available to support the use of PROS in both clinical practice and clinical research. And there should be ample time for questions and discussion at the end. If you'll just enter them in the chat box, we'll be happy to address them during that session. And obviously the virtual presentation mode isn't always ideal, but we're glad to have that opportunity for interaction. So to briefly introduce the topic of patient-reported outcomes, we use PROS to refer to any report that comes directly from a patient about a health condition and its treatment without interpretation by a clinician or anyone else. And it can be helpful to think about PROS in the context of other kinds of patient outcomes. So frequently when the term patient outcome comes up, I think our minds immediately go to the physiologic measures, things like FEV1 in asthma, or hemoglobin A1C in diabetes, or tumor size in cancer, which is the field that Michael and I both work in. There are also clinician-reported outcomes, things the New York Heart Classification system, or in cancer performance status. Sometimes we ask caregivers to report on patients, for example, dependency or functional status. And then there's a whole array of patient-reported outcomes that range from global impressions, functioning and well-being, symptoms, health-related quality of life, and so on. And these PROs are measured using standardized, validated questionnaires. This is an example of a physical function measure from one of the commonly used cancer quality of life questionnaires. And this patient reports quite a bit of difficulty doing strenuous activities, a little bit of difficulty doing moderate activities, and no difficulty at all doing activities of daily living. So if you go through the scoring for this patient, he or she ends up with a score of 60. And you can take that score of 60 and plot it on, for example, a graph such as this one that shows how the patient is doing over time. Another way that these scores are used is as outcome measures in clinical trials and other research studies, where that patient's score of 60 is combined with other patients' scores in that treatment arm, and then compared to the control arm, for example. And today's presentation will be dealing with the display of data for both of those types of things, for showing an individual patient's data, such as shown here, as well as for showing clinical trial or research study results, which Michael will be showing some examples of later. But here we have this 4 time points for this patient. And I just want to ask you to ask yourself, looking at this graph, do you think this patient is getting better or worse? So normally I would do a show of hands, but I'm just going to have to ask you to think in your own mind whether you think the patient is getting better or worse. And so when we've asked cancer patients and clinicians in our research studies to look at this unmarked graph and say, is this patient general well-being getting better or worse? Almost all patients say that the patient is getting better, and many, but not all clinicians say the patient is getting better. Some clinicians have been working in the pro field long enough to know that you can't know necessarily whether a line trending up is better or worse. And when you ask the patients and clinicians to explain their answers, they say things like, well, just generally things going up are better, things going down are worse, and they compare it to things like money or the stock market, where going up is better, and most people upwardly intuit up to mean better. But as I mentioned, for folks who might be familiar with the different scoring variations that are out there, they know that they can't know whether it's better or worse without being told. So here's another example. This is a patient's report of feeling short of breath, and this line is trending down. So I'm going to ask you to ask yourself again, do you think this patient's shortness of breath is getting better or worse? So here's where we run into trouble. So many, I would say the patients who are shown this are split in terms of whether the patient is getting better or worse, whereas the clinicians, the majority think this patient is getting better. And when you ask them to explain their answers, you hear what you would expect to hear, which is if going up is better intuitively, then going down is worse intuitively. But the alternative interpretation of this, which also makes perfect sense, is that a line going down means less shortness of breath, therefore the patient is feeling better. So pain is the clearest example of this. We all think of high pain scores as being bad. as opposed to low pain scores. And so that's why we hear things like, I don't know what's being scored and what those values mean. So a key issue in the graphic display of patient-reported outcomes is whether higher scores are better or worse and how to deal with that. Another issue that we deal with is I'm going to review here. So here's our same patient who completed the questionnaire and came up with a score of 60, but that raises the question, should the clinician and patient be concerned about this score? So it's 60, you know, so what? What does 60 mean? And in fact, we hear this a lot. Patients and clinicians tell us, I have no idea if this is a good score or a bad score. Because of scaling issues, it's not useful. 50 can mean one thing on one graph and something different on another one. And at the most basic level, patients and clinicians tell us that they don't know what the scores mean. And so there's a reason for this. There are many levels of barriers to interpretation for PRO scores, which makes the graphic display of them incredibly important to promote understanding and use. So for one thing, there are many different PRO instruments, hundreds of them. And across these PRO instruments, there's really no standardization in how they are scored, scaled, or in how the data are presented. So as I alluded to previously, on some PRO measures, higher scores are always better. And on other PRO questionnaires, higher scores are always worse. And yet on still other PRO questionnaires, higher scores are better for functional domains like general well-being or physical function, but higher scores are worse for symptom domains like pain or shortness of breath. There's also variation in the way that PRO measures are scaled. So some measures are scaled, for example, from 0 to 100 with the best and worst scores at the extreme, but other PRO questionnaires are normed to, for example, a population average of 50. And because of that, 50 can be completely normal on one questionnaire score, but represent something that's either really good or really bad on a different questionnaire. And there's also variation in how the data are presented. They can be presented in various different graphic formats. They can be presented in tables. For clinical trials, you see variation in whether average scores are presented or the proportion of patients responding to treatment. And because of that, there's a lot of confusion in the field. And in fact, in some research that Michael and his colleagues did, they surveyed clinical oncologists and found that less than half really felt comfortable interpreting quality of life data from the clinical trial literature, but 2/3 were very interested in improving their ability to do so. And when Michael and his team conducted follow-up research to determine, well, what can we do to help clinicians and therefore patients understand PRO scores, the recommendations included things like improving the reporting standards for patient-reported outcomes, such as health-related quality of life, and creating consistent approaches for presenting the data so that patients and clinicians can get used to the way the data are displayed and be able to interpret the data more effectively. So with all of this as a backdrop, we undertook a multi-year, multi-part research agenda to develop approaches for displaying patient-reported outcomes to promote patient and clinician understanding and use. So we started by doing a 3-part mixed methods research study. And in the first part of this study, we examined current approaches for graphically displaying PRO data and asked cancer patients and clinicians what they found was helpful to their understanding and what they found confusing. And then we took the results from part 1 and partnered with a subset of volunteers of part 1 patient and clinician participants and worked with them to try and develop improved approaches for presenting the PRO data. And then we evaluated those candidate approaches in part 3 to evaluate their accuracy of interpretation and clarity of presentation. So just to go through the methods across the research agenda briefly, in part 1, we showed cancer patients and clinicians current approaches for graphically displaying data, and we got their qualitative feedback on what things they found helpful and what things they found confusing. And one of the key things we found in part 1 is that when it comes to showing an individual patient's data, patients and clinicians wanted similar information and they wanted it displayed in similar ways. But when it came to clinical trial and research study data, there was a divergence between what patients wanted to see and what clinicians wanted to see. So clinicians were interested in statistical and indications of clinical importance, but patients really found that information confusing and said that it detracted from their understanding of the data. So after part 1, we pursued 3 different streams of research. One was individual level data for presentation to patients and clinicians, and then we separately addressed how to present research findings and clinical trial data to patients separate from clinicians. And the part 1 results were published in this article in Quality of Life Research. So anyone who is interested in learning more about what we did and what we found can go there. And then in part 2, we actually asked a subset of patients and clinicians who had participated as research subjects in part 1 to volunteer and actually become research partners with our team to help us take the part 1 results and develop candidate approaches that we hoped would perform better. And we went through an iterative process for doing this. So the first step in the process was our research team would meet and look at all of the issues that emerged from part 1. So things like how do you display statistical significance? How do you display clinical significance? And we came up with various ideas for how to handle those issues. And then we brought those ideas to the work groups, which were made up of the part 1 patient and clinician volunteers. And they provided feedback on the various options that we had put forth to them. And based on that, we narrowed down what versions we wanted to test. And we actually did another round of individual interviews with patients and clinicians. And then we took the results of that data and shared it with our stakeholder advisory board. And then the SAB helped us determine which candidate graphic display formats we should test in part 3 of the study. So parts 1 and 2 took place through the Johns Hopkins Clinical Research Network, which is a consortium of academic and community health systems across the Mid-Atlantic. And that enabled us to get more diversity in our study samples, which was very useful. For example, going to Salisbury on the Eastern Shore and getting, a more rural population perspective. And the results of part 2 were published in this paper in Supportive Care in Cancer. And again, if you're interested in more details on what we tested and our process, we invite you to view the paper. And then part 3 was kind of the culminating stage of the research agenda, where we took the candidate formats developed in part 2 and evaluated their accuracy of interpretation and clarity in a broad population. So part 3 was actually conducted via an internet survey that was circulated primarily in North America, but to a certain extent internationally through some of our stakeholder partners. And we supplemented the data collected by the internet with, again, one-on-one interviews with purposefully sampled patients and clinicians from the Johns Hopkins Clinical Research Network. And to give you an idea of the kinds of patients and clinicians who were included in all phases of our research study, for our one-on-one interviews across all 3 parts, we purposefully sampled cancer patients and survivors to make sure that we didn't have overrepresentation of any particular cancer type, that we had at least 10% of the sample that hadn't graduated from college, that we recruited from across the clinical research network, and we didn't have just almost everyone from Johns Hopkins. And then for clinicians, for the one-on-one interviews across parts 1 through 3, they had to be oncologists, but they could come from a variety of backgrounds: medical, radiation, surgical. And again, we wanted diversity from both the Johns Hopkins Baltimore campus as well as from the other clinical research network sites. And for the internet survey, in addition to having self-reported cancer patients and clinicians participate, we also had pro researchers participate and provide their input. And so in part 3, we randomized patient, clinician, and pro researchers to view just one kind of data. They either looked at individual patient data or formats for presenting clinical trial and research study results, or formats for presenting clinical trial and research study results to clinicians. And for the individual patient data, we had over 1,100 participants, including nearly 630 patients, over 235 clinicians, and 250 researchers. And we did one-on-one interviews with 10 patients and clinicians in the clinical research network. For research data presented to patients, we had similar sample sizes, although we underrepresented clinicians here because the primary focus was to patients. And we did one-on-one interviews with 10 patients and 5 clinicians. And then for the data presented to clinicians, we only randomized clinicians and researchers to evaluate those formats. And we did one-on-one interviews with the clinicians. And all the results from part 3 have also been published. We have separate papers for each of the different streams. And again, they've all been published and are readily available. And at the end of the research agenda, our stakeholder advisory board suggested to us that we had developed a research base that was sufficient to develop recommendations for how to display pro data, but that we should undertake a separate consensus development process for doing so. And so we applied for and were fortunate enough to receive follow-up PCORI funding to bring together a broader group of stakeholders who reviewed the evidence base from the research I just presented, as well as the few other studies that had been published on this topic, and use that evidence base to develop the recommendations that Michael will be presenting. And so we used a standard modified Delphi process where we conducted a webinar with all of our stakeholders to orient them to the meeting process and to review the evidence base, and then we developed and administered a survey to assess initial levels of agreement for recommendations. And then we shared the survey results and brought everyone together in person for a meeting to formulate our consensus recommendations. And then those recommendations were ratified via a post-meeting survey. And the results of that were published in this paper called Making a Picture Worth 1,000 Numbers. And again, it is readily available in quality of life research. So now I'm going to turn it over to Michael, and he's going to go over the actual recommendations for displaying the results for patients and clinicians across the 3 applications.
Thanks, Claire. I've lost my video feed, so I'm hoping you're able to hear me and see my screen. Is that true?
I can hear you, but not see your screen.
Okay, let's try that again then. How's that?
That is good.
Okay. So there we are, back on track. Good day, everybody. Really a pleasure to be here, and I'll reiterate Claire's comments about how nice it is to have this opportunity and share our findings with all of you. So it's my pleasure just to show some of the results of part 4 of the study that Claire has just summarized. We basically wanted to give you a sense of what we found. We did have some caveats that when we had this Delphi process and arrived at our recommendations, we did not account for impact of training or the impact of learning. One of our premises is that if clinicians start to see PRO data displayed in the same way over time, they will learn, and they will learn to interpret graphic formats much as they have learned to interpret Kaplan-Meier plots and forest plots of meta-analyses. But for now, we're focusing on simple interpretations and for research studies comparing 2 hypothetical treatments. This table is in Claire's paper that she just summarized, or she just mentioned rather, which summarizes the Delphi recommendations. The point of this slide is that there are a number of recommendations that we made according to patient and physician consumers. So go read, have a look at the paper, take these details. I'm just going to touch on some of these today. So I'm going to start with recommendations for displaying individual patient data. So this is a patient that I might have seen in clinic today. Today is here, and the last few observations are shown there. The first thing you'll notice about this display is that there's a line plot of this patient's scores. We did debate at the Delphi, and quite a bit earlier in our part 1 and 2 of the study, whether line graphs were the best way to show individual scores. Some people display these by bar charts. Some groups show patient scores in other ways. But consensus in the early qualitative work and consensus amongst the Delphi evidence-based review was that line graphs are probably the best way to show individual scores over the time, even though they're not perfect. So here's today, this is physical functioning. So this patient is getting worse, as Claire mentioned. And what we hope to show on this display is some of the key characteristic features of the display that were the basis of the Delphi recommendations. So because physical functioning going down is bad, but symptoms scores going up is bad, it's imperative that we separate scores that have one directionality of interpretation from scores that have different directionality of interpretation. So we put labels in, pretty in your face. Lines going up mean better able to do physical activities. In our qualitative work, people found that that annotation was quite helpful. And likewise, in the other symptom scores, line going up means worse fatigue. Also, you'll see this teal line here that creates a physical separation in our display between scores that have one directionality of interpretation and scores that have a different directionality of interpretation. So which way is up is really important, and these are some strategies that help clarify the directionality piece of the display. The other thing that helps inform directionality is very clear labeling of the y-axis. So here, very high reinforces the fact that up is good, whereas down here, the label severe reinforces the fact that up is bad. And that labeling of the anchors is very useful to interpretation of the graph. In addition to that, some of the intermediate axis labels can also help orient the reader as to how to interpret a score of 60 or a score of 30, for example. These intermediate axis labels are most useful when there's some data that informs where to place these labels, bookmarking experiments, for example, or other strategies that can help find the difference between a poor score versus moderate or moderate versus very high. Ideally, these labels would be used in conjunction with some of that evidence that allows them to be placed. But if that evidence exists, their additional placement can really assist in how to interpret not only directionality, but magnitude of the scores. Some PRO instruments have reference values for the general population. So this helps a patient or the clinician interpret how the base score differs from population average scores. So the recommendation was to include those where readily available. And also, as Claire mentioned in her presentation, some delineation of when scores become possibly concerning, much like you would see in the lab result with a calcium level, for example, outside the normal range. Some visual annotation of where the scores become concerning and in what direction they become more concerning, people found to be very useful. I'm going to move now to types of displays where we're doing clinical trials that compare group scores. So the question to be answered here is, given 100 patients that receive treatment A and 100 patients that receive treatment B, which treatment strategy has their PRO findings? As I mentioned, patients have different needs in these displays than do clinicians. So here's an example of a summary of the visual recommendations for average scores over time. The first thing that you'll notice is the graphs are relatively simple. There's a JCO type of color coding that we chose to delineate treatment X from treatment Y. Again, there's labels for directionality. The domains are separate, where scores going up are different than for functioning are different than scores going up for symptoms. The same labeling strategies apply, and you'll also notice some labeling of the lines that helps patients easily indicate treatment is much beyond looking simply at the legend. You'll notice some time points here are depicted as well, so patients can get a sense of what happened over time.
Michael, can you speak up just a little bit?
How's that? Is that better?
That's much better.
Thank you, Claire. So the last thing I want to show is our consensus recommendations for when clinical trials are displayed in the published literature. And this is really for clinician uptake and researcher uptake so that they can communicate these results to their patients indirectly. So you'll notice here, same general arrangement, line graphs displaying group score, group average scores over time. This is in grayscale because most publications will publish these results in grayscale. So our philosophy was that anything that we displayed needed to be interpreted in grayscale. Color would be of use if it's available. grayscale had to do. So you'll see again, treatment X is a different grayscale than treatment Y. The lines are labeled, the scores are displayed over time. In addition here, in addition to the labels for directionality and the separation of domains, we added a couple of different annotations. The clinicians wanted to know when differences in scores were clinically important or met some criterion for minimal important difference. Since some of these close scores might be statistically significantly different, but not clinically meaningfully different. So we decided to annotate where the difference in mean scores between arms met published criteria for clinically important. So that's in the legend and it's annotated. In addition to that, clinicians generally want to know whether the differences between arms are of statistical significance. So there's two components of that that are reported in the literature. One is whether there's a statistical difference between arms over time, considering all time points. But that p-value is given in conjunction with the labeling arms. And the second possible statistical interpretation is whether at each time point, differences between curves are statistically significant. And what the recommendation was that these statistical differences are displayed using confidence limits to delineate important statistical differences rather than p-values at each individual step. So one p-value for the comparison of the curves over time, confidence limits to show statistical differences at different points. It's clear pretty much from part 3 of the study that Claire described when clinicians responded to our surveys. Some clinicians get these things, some do not. But what clinicians do appreciate is some holistic summary of whether the difference between the curves are of clinical significance and are of statistical significance. I'm going to turn it back to Claire to mention some additional tools that can help the uptake of PROS for interpretation and use.
Claire, you're muted, I think.
Oh, thank you, Michael. Unlike being me myself, who was completely muted, I think Michael's audio went in and out a little bit. So I just want to pause here and see if anyone has any questions or needs us to go back and review anything regarding what he just presented. So if you do, I'll just give you a chance to put it in the chat.
My apologies, folks, for the audio. I'm sorry about that.
I think it was just your microphone picked up some things better than others. Okay, well, we'll have more time at the end also. We should have plenty of time at the end for discussion by design. So we'll definitely come back to anything that anyone has questions on.
Thank you, Claire.
But Michael and I thought it would be helpful to put into the context of the general use of PROS in clinical practice, as well as the general use of PROS in clinical trials and research studies, this data visualization piece, because it really is just one piece of optimizing the use of PROS in clinical trials and in clinical practice. And there are other tools out there to help with the different aspects of doing so. So, you know, we've highlighted the recommendations for pro data graphic display, but, you know, where do these data come from and how to use them effectively across the trajectory of either clinical research or clinical practice? So I just want to start with some of the resources that are available for individual patient data. So this is using an individual patient's data to inform his or her own care by monitoring how they're doing. And key aspects of using PROS in clinical practice involve collecting the PRO data, reporting the PRO results, interpreting the PRO scores, and acting on the PRO findings. And our recommendations for graphic display deal with reporting the results and helping to interpret the scores, but there are other aspects of the process that also require attention. And there are these other resources available to address those different aspects. So the first is the User's Guide to Implementing PROS in Clinical Practice, which was developed by the International Society for Quality of Life Research originally in 2011 and then updated in 2015. And the goal of this user's guide is to help clinicians and researchers who are interested in implementing a pro-clinical practice intervention walk through that process. So the user's guide goes through each step involved in implementing PROS in clinical practice, starting with, figuring out what your goal for the data collection is, to figuring out which questionnaire to use and how frequently to administer it and how to report the results. And for each of these considerations, it offers a range of options for how they can be dealt with. This is not a situation where there's one right way to do it. There are relative advantages, disadvantages, and resource requirements depending on the approach. And so by offering options, the user's guide gives the users the opportunity to figure out which trade-offs make the most sense in their particular context. In 2017, as a follow-on to the ISAQOL User's Guide, also this time with PCORI funding, a user's guide was released about integrating PROS in electronic health records. And it's organized in much the same way that the ISAQOL User's Guide is, and that it walks step by step through the considerations involved in putting your PRO data in your EHR. And addressing the EHR specific aspects of things like score display and acting on the results. And it also provides not one right answer, but a range of options with their relative advantages and disadvantages. One thing that Michael alluded to in his presentation of the recommendations was this idea that, along the y-axis, we should provide descriptive labels of what the different numerical scores mean, and we should include data for reference populations if they exist, and we should provide some delineation of what PRO scores are concerning and potentially require clinical attention versus those that don't. But as he also alluded to, for a lot of PRO questionnaires, that information is not yet available. So in 2019, we published a special supplement to the journal Medical Care, which is, we refer to it as a toolkit because the different papers in the supplement provide different methodologic approaches for addressing those very questions of figuring out mild, moderate, severe, for identifying reference scores, for figuring out what scores are possibly concerning. And the other thing that is covered in this medical care supplement are approaches that various electronic PRO systems out there have actually used for aiding interpretation as well as facilitating clinical action or patient action to be taken in response to the scores. In terms of research data, there are also a set of resources available. So if you're doing a research study, there are multiple things you have to do in addition to figure out how to display the data. You have to figure out which PRO questionnaire you're going to use, include the relevant information about PROs in your protocol, analyze the data rigorously, report the findings clearly, and be able for clinicians to interpret and use the data in practice. And again, there are resources available to help folks who want to use PROs in research studies with each of these steps. So there are various different guidance documents out there about how to select which PRO measure to use for a research study, but they're very similar in their recommendations. This one put out by ISAQOL specifically recommends the minimum standards for a PRO to be used in patient-centered or comparative effectiveness research. So it can be used to help you figure out which pro measure of the hundreds that are available might be appropriate for your particular research application. Some of you might be familiar with the SPIRIT guidance for how to write a randomized controlled trial protocol. There's a special pro extension that goes through all the details you should include about the PRO part of the study, such as what questionnaire you're using, how often it's going to be administered, by what mode, how the data are going to be analyzed, and so on. In terms of analyzing pro data, this is an area where we're trying to encourage more standardization and consistency in the field. And to that end, a consortium organized by the European Organization for Research and Treatment of Cancer has developed a consortium which has developed a taxonomy of research objectives that could be used for pros, such as comparing mean scores over time versus the proportion meeting a responder definition. And for the various research objectives, they've outlined appropriate statistical methods for analysis, and they also deal with missing data, which in certain fields, such as cancer, can be really important. Similar to SPIRIT for writing pro protocols, CONSORT provides general recommendations for how to write up a paper that reports on a randomized controlled trial. And the CONSORT Pro extension provides additional recommendations for what you should describe about the pro part of your study, such as what pro measure you used, what your specific pro research questions were, when the data were collected, what a clinically important difference is, and so on. And then finally, this checklist, which is referred to clinicians in the title, but could be valuable for multiple different users, is meant to help people who don't work in the pro field read an article that reports on pros and be able to evaluate whether they did a good job with the pro study, what the pro findings mean for their particular clinical application, and be able to use the data in practice. So finally, having, Michael and I and others in the field, having worked for the past decade or so to develop these resources for optimizing the use of pros in clinical trials, about a year and a half ago, we formed the Proteus Consortium, which stands for Patient-Reported Outcome Tools, Engaging Users and Stakeholders. And our website is theproteusconsortium.org. And what Proteus is trying to do is ensure that patients, clinicians, and other decision makers have the pro data from clinical trials they need to make the best decisions they can about treatment options. And to do this, what we're doing is partnering with the key stakeholder groups to disseminate and implement the resources that we've presented today that are there to help people optimize the use of pros in clinical trials. And so this is just a list of the organizations who are participating in Proteus, and they include methods and research organizations, the groups that actually conduct clinical trials in cancer, research funders, government and regulatory bodies, and clinician and patient advocacy groups. So we're working through Proteus to promote the optimal use of pros in clinical research so that patients and clinicians can use those data. And the next time Michael and his colleagues do their survey of clinical oncologists, hopefully many more will feel comfortable using those data for their patient care. And so with that, we would like to open it up for questions and discussion, and we have about 10 minutes for that. So thank you all for participating today, and we look forward to hearing your thoughts. So just anyone who has any questions, if you want to type them in the chat. Are there questions?
If you're having trouble with the chat and you'd like to unmute to ask a question, that would also be fine.
Well, the question is, will a copy of this presentation be available? So this presentation is being recorded and will be available. I don't know, Laura, if you want to provide details on that.
Sure, it will be, it should be available on the BEAD Core website eventually. Claire, if you would like to share the slides, I could email those out. I don't know if that's something you'd like to do or not, but I could also share the recording. So just email beadcore@jhmi.edu and we'll give you what we can.
Yes, it is a lot of material to take in, and I'm Snyder at jhu.edu. And so if people have follow-up questions, you're welcome to email me. And also I just, you know, I think the slides can sometimes be hard to interpret standing on their own, but we could circulate the papers that report on everything, and then you'll have everything that we presented today and more available for your consumption at your leisure.
Yeah, if you want to pass those on to me, then I can have them available. If people want to email BEAD Core, I can send out the links to the papers or the papers themselves.
Absolutely. So Proteus was originally funded by PCORI. So the question was, is Proteus funded by a specific organization? And Proteus, the formation of Proteus was funded by PCORI, and we currently have an unrestricted grant from Genentech that is supporting Proteus right now through about a year from now. So we are hoping and pursuing additional funding because we hope that Proteus will become a permanent fixture on the scene in terms of promoting excellence in clinical trial pro data. So thank you for that question. Any other questions? While people might be thinking or typing, I just wanted to take this opportunity to thank the team that we had that helped us across the research study as well as the Delphi process. So we had collaborators and co-investigators from Johns Hopkins, and then we had stakeholder advisors, and then we had meeting participants. So it was, as well as all the research participants. So it was really a big inclusive process, and we were very appreciative of everyone who participated. So just want to, I think that was clear from our presentation how many people were involved, but just wanted to put out a big thank you to them explicitly here. Okay, if there aren't any other questions, we can turn it back to you, Laura. Oh, well, I guess one last thing that Laura didn't mention in her intro, but I definitely want to mention now is that the BEAD Core will be starting a pro consultative service on July 1, and it doesn't start until July 1, so just keep that in mind. But starting July 1, if folks are interested in using PROS in either a research study or in a clinical practice application, a certain number of hours are being provided gratis with support from the Cancer Center and the ICTR. And so there will be expert consultation available to you to help you with things like picking a PRO measure or interpreting the PRO findings or analyzing the PRO data or any of the steps we talked about for clinical practice and clinical research. And so we're very grateful to the Cancer Center in cooperation with Oncology Biostatistics, as well as the ICTR, who are funding this pilot phase for a couple years to really promote the use of PROS, both in research and practice, to promote patient-centered care. So Laura, I don't know if you want to add anything about that, since you'll be coordinating that effort for BEAD Core.
Thank you, Claire. Yeah, as of July 1st, we will be offering this new service line, especially to faculty and sponsored for faculty and fellows in oncology. And if you would like more information about how to sign up for the services, email beadcore@jhmi.edu. You just have to fill out a simple form in iLab and we can direct you to the right person starting July 1st. And we offer all kinds of other services as well, for everything from data management, setting up RegCap, databases, that sort of thing, to really complex analysis and grantsmanship and the whole gamut of research support services. So we're really excited to have the new PROS line coming on. And thank you so much, Claire, for your time today. And Michael, thank you very much.
And just one clarification. So it's available across, because it's also being supported by the ICTR, it's not only available for oncology, it's available for across anyone supported by the, or coordinated through the ICTR.
I have to double check the specifics, but that sounds, you've been part of more of those conversations than I have, so I think that must be correct.
Yes, I'm quite confident about that.
Okay, good.
Yes, the Cancer Center was very generous, and the ICTR is partnering with it to make it more widely available even beyond cancer. So.
Great.
And well, thank you, Michael, for dialing in from friendly northern Canada.
Great White North. Have a great day, everybody. Thank you for attending.
All right. Thanks, everyone.
Bye-bye.